Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I'll be your moderator. We're excited to welcome Dr. Mark Geisberger as our speaker today as he discusses Class 5 restorations, specifically materials and techniques for simple, predictable, and beautiful results. Before we get started, we got a couple reminders for you. At any point during today's webinar, we do encourage your participation. Please type any questions you have into the Q&A section of your control panel, and we'll answer them live at the end of the presentation. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. And this webinar is sponsored by Clinician's Choice and powered by Hands Online Live. Before I welcome Dr. Geisberger, I do want to mention that we will be providing a list of all the products used in today's webinar. With that, I will turn it over to you.
Well, thank you, Adam, for the introduction, and welcome everybody to today's program. My name is Dr. Mark Geisberger, and I'll be talking about Class 5 restorations with you today. So what I'd like to do is get into the program, just a bit about me. I hail from San Francisco, where I taught at University Pacific School of Dentistry for 27 years until 2018, when I became an adjunct clinical professor. For years there, I ran the Department of Restorative Dentistry, 15 years as department chair. In addition to that, I practice in Marin County, California. I practiced with my father and my brother since 1991, celebrating 30 years in dentistry this year. And I'm a product evaluator and do a lot of consultation for companies about materials and technologies that they may develop. In addition to that, I'm a speaker with Catapult Education out of Chicago, Illinois, a large speaker bureau run by Lou Graham. I'm happy to be a member of that. And I maintain my family, or actually they maintain me and keep me sane and busy. So with that said, I want to thank and disclose that Clinician's Choice has sponsored today's program. And I want to thank them for doing that. I'll be going over a few of the products from them that I use on a routine basis for Class 5 restorations. And it's important to recognize that Class 5 lesions are abundant in our practices. In fact, I think they're an untapped potential in most dental practices. Now, we know there are really Class 5 lesions come in different forms, whether they be carious lesions, abfractions, erosive lesions, or even toothbrush abrasion can all cause these Class 5 lesions to exist. But my experience in evaluating these and watching these come into my practice is that dentists really treat the carious ones, but sometimes don't bother to treat the abfractive lesion, erosive lesion, or even abrasive lesion, which I considered a disease process as well. And in my practice, I see disease, I treat disease. So I think you can broaden your treatments by including the ones that aren't always treated. Now, I want to give you just some heads up on how to look at these. We know abfraction is that pathological loss of tooth structure due to my biomechanical load, often occurring on the opposite side of loading. And we see these all the time on the facial aspect of teeth when they're loaded on the lingual, forces brought to bear. And they have these very sharp appearances where the enamel's literally cleaved off the tooth. And that's different from erosive lesions that are really the irreversible loss of dental materials due to acids, which do not involve bacteria. And that's really the distinction between caries, which involves bacteria, and erosion, which does not. And then finally, abrasion lesions are those non-carious mechanical wearing of tooth structure from interactions with other objects. Similar to toothbrush or toothpaste, one of these type of things can cause abrasion. But you have patients do abrasions with other things, odd habits they may or may not have. Now, it's important to recognize that both the abfractive lesion and the erosive lesion will look a little different than the abrasion lesions. Abrasion lesions tend to be highly polished because they've been brushed, they're shiny, whereas erosive lesions tend to be more matte finish because they really actually have been etched. And abfraction has that very cleaved or linear look. So we also see combination lesions, meaning the patient has some erosive tendencies coupled with abfractive lesions. And you see those in individuals with a lot of bruxism, and maybe that bruxism comes from a process that's protective in nature, bringing up acids from their stomachs. So class 5s come in all shapes and forms. And what I'm really going to do tonight is touch base on how I like to treat these and the protocols and products I use to do that. So I'm going to show you a few clinical cases. And I'll take you back to a historic case with this maxillary cuspid. Now you can see on the lateral incisor and the bicuspid these have been treated. On this cuspid, I chose to use a process that I'll describe today with an irregular bevel. And that irregular bevel really involves the enamel. And I'll show you that during my short demonstration I'll do. But when we do that irregular bevel, we can really obscure these materials. The gingival area is controlled with a retraction cord that I'll show you. And the products I use really allow me to make these literally disappear and last the patient for years and years to come. So when we talk about the technique, I'll use incremental layering, whether it's with a flowable or a conventional composite. If I have a very dark root, sometimes I'll consider an opaquer to block that out. And I'll use retraction cord prior to the preparation to get me that little gingival retraction. Well, with the class 5 retraction cord, I use one of two products, either clinician's choice Record or ultradense ultrapack cord. These are both knitted cords rather than a braided cord, which tends to unravel. And I'll use the Fisher's ultrapack packer from Ultradent to place those cords. And I'll place the cord prior to preparation. And that's very effective in doing that. Now, with a class 5, we were all taught a standard bevel. But what I'm going to suggest is if you take that standard bevel and modify it, your restorations will look better. Now, with a standard bevel, we were taught that bevel should be approximately 1 millimeter, a half millimeter at 45 degrees angle on the enamel. And that would do two things. It would help hide the material and would increase the surface area to bond to. Well, what I do is actually called an irregular bevel or a starburst bevel, and it looks different. It varies not only in height, but in depth. So when we go across the tooth, while we may remove the same amount of enamel, I'll vary the bevel, and this really helps blend optically the composite you choose to place on top. And I'll show you that technique as we go through this. Now, I'm going to use a product called MPA Max. I won't be etching because here at my demo site, I don't have the ability to etch, but this is a total etch adhesive. And I'm going to show you the use of that on a clinical case. So here we are with that retraction cord being placed, anesthesia has been given, and these are very large abfracted lesions. Now, if you have an air abrading system, I would go ahead and air abrade after you get everything isolated, get that dentin air abraded, especially when you're dealing with toothbrush abrasion, which tends to be highly polished and harder to bond to. Then I place the irregular bevel. And the irregular bevel, remember, varies in height and depth. So we place the irregular bevel on both these teeth, and we go ahead and apply our etchant, our max etch. We rinse that, dry it, and then we go ahead and apply our total etch bonding agent, the MPA Max, and we scrub that for 5 seconds and air thin for 5 seconds. Now, I'll get into a little bit about that adhesive, but it does wonders for getting high bond strength to a class 5 and really eliminating any possibility of sensitivity. So we place our adhesives. I like to do 2 teeth at once, and then we go ahead, cure that, and place our flowable composite. Now, when I place a flowable, I like to use an explorer to move that flowable around. So here I am putting a first layer on both teeth, using an explorer tip to just get that into the deepest part of this abfraction. And then I'll go ahead and restore that completely with my remaining material. Now, tonight I'm going to demonstrate the use of an overlaying composite. But if you look at our hands-on live course and take my class 5 course, I'll take you through restoring 3 teeth with 2 different techniques, both of which I use in clinical practice. Then we go ahead and we pull our cords and we begin the refinement process with a carbide finishing burr. And I get these nice and smooth using a very slow stall out speed. Then I go ahead and polish these, and we get a beautiful result. And when the patient sees these, they see nothing. Now, what I want you to look at is that area where I did the irregular bevel. And honestly, these are indecipherable. You cannot see them. And that's the difference between that irregular bevel and standard bevel. Now, I want to show you using a selective etching technique. So this would be for those of you who may have a self-etching adhesive and you want to consider a self-etcher, but you may still have an enamel margin. I would recommend then a technique for you called selective etching, where we apply an etchant, a gel etchant to the enamel, and then we use a self-etching adhesive on all of the tooth structure. So here's a little clinical case on an upper bicuspid where we're going to restore that. We do the same technique. We get our retraction cord in place. You can now see that gingival margins, the terminus of the tooth is beautifully exposed. We go ahead and we prep that. Then we use a micro etcher if we have it. And then to do selective etching, we apply our gel etchant on the enamel only. And that's critical when you're doing selective etching. At that point, we turn to our self-etching primer. This happens to be using Peak SE from Ultradent. And then we go to apply our bonding agent, in this case, Peak Universal Bond. We get that in place, we air thin that, and we go ahead and light cure and restore. So here I am placing my flowable. We get our flowable in place, and we go ahead, pull our retraction cord, and then we do our little finishing. Now, it's important to pull the retraction cord before you attempt to finish these. Otherwise, you'll pull the cord with the burr, and that'll be an exciting moment in clinical practice. So be real careful with that. So when these all finish, they literally disappear. I love doing class 5s. This is one of my favorite things to do. They're quick, they're painless for the patient, and they look beautiful. So I want to go over some of the products I'm going to demonstrate tonight and let you know what I'm using. First, I'm using a etchant material and bonding agent that is a 5th generation. It is still a total etch technique, not a self-etcher, which requires that I apply the gel and etchant, the max etchant, to the entire surface to be restored. Then I rinse it off, air thin it, and apply our MPA Max. Now, MPA Max has a number of advantages I want to point out to you. First of all, it's got a very high bond strength to both enamel and dentin. This is what we call a filled adhesive, meaning it has some glass in it at about 7.5%. It's an ethanol-based carrier, and it's got a proprietary UDMA monomer in it. In addition to that, it has 0.2% chlorhexidine, which actually has been shown to be an MMP inhibitor. And best of all, when you thin this out, it gets down to 2 microns, which is incredibly thin. And believe it or not, the thinner you can get a bonding agent, the higher your overall bond strength. So when you see bonding agents that test really high in bond strength, the next thing you should look at is their film thickness. And I'll bet you each and every time they're under, say, 8 microns or so. And that's really important. So lots of products that I've used in the past. These are some of them. Single Bond from 3M, PQ1 from Ultradent, and OptiBond Solo Plus from Kerr. Those are all alcohol-based products, and they all happen to be filled products. But the one tonight I'm using is MPA Max, and I'll demonstrate that to you shortly. Now, in addition to that, I'm going to use 2 composites tonight. One is a flowable, one is a conventional composite. And this product from Clinician's Choice is called Evanes. Evanes is a beautifully blending composite based on nanotechnology and barium glass with silicon dioxide particles. It's got yttrium trifluoride for opacity. It's got that proprietary monomer in it. It's filled 82%, which makes it a highly filled composite with a very high flexural strength and compressive strength. But the neat thing about this composite is it's available in lots of different opacities and shades. Now, those are 2 different things. Opacity has to do with the amount of translucence that occurs through the material, where the shade is simply the color. So when you look at this, we can get it all the way down to an enamel clear, which is only 60% opaque, all the way up to a dentin, which is 90% opaque. And that's important when you're really trying to make restorations disappear, that you control not only the shade, but the relative opacity. And this composite gives us that ability. So lots of options in color. Tonight, because I'm working on this Typodon, I'm going to be actually using a dentin shade, but a fairly light dentin shade for this procedure. Now, we'll also demonstrate a flowable composite. And what's neat about these is you can buy it in a syringe or these preloaded compules. This is filled 62% by weight and 48% by volume, which is a relatively highly filled flowable. And what that gives you is high flexural strength and, again, very high compressive strength. But that high filler content also gives you a flowable that stays put. It's not one that's going to slump on you or run all over the place. And if you're using a flowable in a class 5, that's a real good idea. So we'll be demonstrating that. It comes in varying opacities, 3 different opacities: enamel, universal, and a dentin opacity, an A2 dentin. And this really is a nice flowable composite for this technique. There's a product that works really well called Resin Blend that helps as a sculpting liquid. It's a clear sculpting liquid, so it won't provide any yellowing on your restoration. And I'll use this when I need to sculpt and move composite around. Now, I have by my side here a composite warmer, which is something I've used for the past 12 years. I've been warming composite a long time. And what I want to let you know about warmed composite, there's lots of literature on this that's emerged over the last 10 years. Now, they're going to send you this presentation. I won't have time to go into the literature. That would be a 2-hour conversation. But suffice it to say that the literature says that when we warm composite, we get more complete curing, a decrease in film thickness, which allows it to flow more readily, and we get more complete curing. So I've tagged some literature on here. When you get this presentation, if you want to go back through it, I welcome you to do that. But this composite warmer has my gun preloaded with the flowable and my shade of Evanesce right here, warming and ready to go. And it's warmed to around 150 degrees. So this is literature. I'm not going to go into this too much, but really talks about the effect of preheating on composites and what happens to monomer conversion. And believe it or not, a warm composite cures more completely than one at room temperature. There's been lots of articles that show better adaptation with warm composite. And that's been my clinical experience, but there's articles that have really shown that, how you can get a better adaptation at the critical spot with a warm composite. There's lots of research that shows heated composite decrease in water absorption, which is an interesting phenomena of the warming process. So that's important to recognize. Now, one thing that came out in the literature is that you have a limited time when you heat a composite, meaning you've got less than about 2 minutes to get the composite in place and sculpted before it loses so much of its heat that it's really not clinically effective anymore. So this is a technique that I use where we'll work quickly through this so we don't lose that ability. Now, I'm going to be curing tonight's restorations with a Velo curing light from Ultradent. This is my favorite curing light on the market. Why? Because it contains 3 different LEDs designed to really output at varying wavelengths and really cure our composites completely, giving us that broad curing range to cure not only camphorquinone found in most composites, but say PPD and TPO, 2 other photoinitiators that are becoming more and more common in dentistry. So I'll cure this in what's called the standard mode, which outputs 1,000 milliwatts per centimeter squared. And I'll cure that for 10 seconds with a final cure of 20 seconds over the restoration. You can use it in higher power modes, but when you go up to 1,400 milliwatts, you still have to do 2 4-second cures. You don't save a ton of time, just 2 seconds. So there are other modes. Now, one thing I want to really bring to your attention is the need to check your curing lights for their output. And there's some great systems on the market that do this, but it's really important. And this study long ago showed that 43% of lights that were tested in practice weren't working all that well. So it's important to recognize we have a built-in radiometer that we use, an LED radiometer, on a monthly basis to check how much output our lights has. Is it at that 1,000 milliwatts as the company would tell you, or is it lower? So it's important to recognize, because that really impacts how long you need to cure a material. You want your lights functioning properly. Now, for a class 5, I'll use really 2 instruments. The first is called the REJ number 10, or Dr. Ronald Jordan number 10 composite instrument. And that's from Clinician's Choice to place the material. The other instrument I use routinely is a pigtail explorer, or a standard explorer, to move my flowable composite around, and I'll demonstrate that in just a few minutes. In addition to that, I'm going to be contouring the line angles of this restoration with the use of a disc that works really well at both the mesial and distal line angle to get that nice curvature into the proximal surface, and I'll show you how to do that. And I'll be using some disposable burrs, neo burrs from Microcopy. I'll use a 330 carbide disposable burr, as well as a finishing burr in the cervical region of the tooth. So I encourage you to look at those. The other product I'll show you tonight, and this is one I absolutely love, is called the ASAP All Surface Access Polisher. This is a 2-step polishing system that gives you an incredible luster on your restorations in 2 steps rather than 3. This version I'm showing you here is autoclavable up to 30 times or more. There's also another version called the Dailies that I'll show you over my camera shortly. The first one you use with light pressure at 44 microns to get a smooth surface. And then finally you hit that with the second step, which gives you that very high luster on your restoration. Now, these happen to be the daily versions, and these are designed to be used not once, but throughout the day. And then you throw them away after they've been autoclaved throughout the day. So they're kind of a one-day use for multiple patients throughout that day, then you discard them. So it's another option for you, a little more disposable for those of you who like disposability. Now, here's just a quick clinical case that I did. And I really actually like to treatment plan these in quadrants if I can. So this is a patient with a very thin gingival biotype, lots of recession, both some abfracted lesions coupled with a little erosion. And we did all 3 of these together. So I'll place the cords together. I'll go ahead and restore together. And we can get a brilliant result with these very quickly. And these all have that irregular bevel I demonstrated. Now, I encourage you to take my Class 5 course with Hands-On Live and all the other courses Hands-On Live has to offer. But if you take that course, you'll be sent models and all the equipment to do this. And I'll show you with these 3 restorations. We actually restore 3 teeth during that program and take you through the whole process step by step. So I encourage you to look at Hands-On Live programs. Now, that's it for the lecture part of the program. And I know there's some questions. Well, we'll get to those at the end. We'll have plenty of time for that. What I'm going to do now is just give you my email address. If you have any follow-up questions for me, feel free to email me. And I'd love you to follow me on Instagram at Marin Dentist, or on Facebook at Mark Geisberger DDS. With that said, I'm going to give a shout out to Bob Margis, who is offering a hands-on line course on April 6th. That course is Restoring Discolored Central Incisor, and or my course on April 8th, Mastering the Class 2 Restoration. So I encourage you to look at both those courses and look at that. You get a discount if you use the friend HS code at Hands Online Live for either one of those courses. And take advantage of it. It's a lot of fun. And I'll go over this step by step during that program. Well, with that said, I've got to bring up my camera. So you've got to give me just a few minutes to power that up and get where we need to be for our live demonstration. So I've got to pull that up. Not only that, I've got to go ahead and get my loops on and get myself set up that way and get on a pair of gloves. So just bear with me. Now I'm going to take you through this technique for the duration of this program. And I'm going to go ahead and glove up here. And I'm going to go ahead and restore this maxillary first bicuspid that has a simulated abfractive lesion in it. And I'll show you that. Let me get my loops on here, make sure we're good. So when we look at this, we can see that very large abfraction lesion in the side of the tooth. When I turn to the side, you can see how large that is. And it's kind of the classic abfraction lesion. Now, the first thing I'm going to do is go ahead and place what we call our irregular bevel. I'm going to do that with a 330 burr. I'm going to zoom in just a bit and get this in focus just a bit for you so you can really see this, this procedure up close. Now, I'm going to take my handpiece and I'm going to do my irregular bevel. Okay, so to describe the irregular bevel, it should be as irregular as you can make it. So for instance, we want this to go up and down. Now, when you tell a dentist to do an irregular bevel, they make a very regular, irregular bevel. So what I mean by irregular is it really should be one of your worst preps ever. It would probably fail you right out of dental school. So I'm going to come up here and I'm going to vary that in height and depth. Okay? And we want to keep it irregular. Okay, just like that. And, my friend David Clark, who does a lot with BioClear, calls this a starburst bevel. You can call it whatever you like. It's an irregular bevel. I'm going to turn it to the side so you kind of get the sense of that irregular tendency. So it varies in height and depth, and really it goes across the tooth in such a way that we're really going to hide our restoration. So I'll come up and down and I vary it in areas that are different. Now, I would have placed a retraction cord first before any burr, but the reality is this typodont does not receive retraction cord very well, so I can't do that. Now, the next thing we're going to do is consider what etchant we would use. And really your choice here in etchants would be, am I going to go a total etch and just cover the entire prepared surface in an etchant, a phosphoric acid etchant, and then use, say, MPA Max? Or do I want to do a selective etch technique? Now, what I do not advocate for a class 5 is a self-etch alone. What I mean by that is if you self-etch the dent, you'll get a very high bond strength. But if you self-etch this enamel, you won't have nearly as high as a bond strength. So Newman showed that very clearly in his research when he examined those bevels. So I'm going to go ahead and do a total etch. Now, chairside here, I do not have the ability to rinse. So we'll pretend that I applied my gel etchant and rinse that off for 5 seconds with water. Then what I do is go ahead and I place my adhesive. So I'm going to dispense my adhesive. And one thing to keep in mind is because I'm using a bottle system, I want to recap that immediately so that we don't have evaporation of any of the ethanol in there. And we don't want to pre-dispense that. We want to dispense it right at the time we use that. Now, when you apply your bonding agent to the surface, it's important that you scrub that into all of the surfaces to be bonded, okay? So I usually do what's called a 5-second count, and I go 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. And that allows that material to penetrate the dentinal tubules, seal those dentinal tubules. Then the most important thing is to disperse this as thinly as possible. Because remember, I mentioned that your higher bond strengths actually come when you get the film thickness of this adhesive down as thin as you can. So I go 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Now, one of the critical errors I watched many of my dental students do at this phase was to just give it a quick blast of air. Well, what you have then is pooling of your restorative bonding agent, and that's not a good thing. I'm going to bring my light in here, and I'm going to go ahead and cure this. Now, I'm going to cure this for a full 20 seconds, just to ensure that I get my area fully cured. If you notice, I'll move the light around just a little, just to get different aspects of the light onto this restoration. That also helps diminish any heat that you generate. So at this phase, I'm going to go ahead and place my flowable composite. Now, in this case, I'm using my flowable that has been placed into my gun, and I'm going to introduce the tip to the preparation. Now, the nice thing about this Evanesce flow is this comes in ready to go format. So I can get this right in here, and I'm going to place this into my restoration and allow that to express out. Now, remember, before we lose all our heat, we have about 2 minutes to get this in place. Now, I've placed my first layer of flowable. I put my gun back into our heating element. Now, at this point, what I'm going to do is I'm going to come in here and I'm going to very gently and purposefully move my flowable to the areas of the preparation that I want it to go. And the nice thing, which you'll notice when you try this flowable for the first time, is that it really doesn't slump. It holds its body, okay? So now I've got my flowable in place. I'm going to turn it to the side so you can see I have not in any way, shape, or form filled the entire aspect of that, because we're going to overlay this now with our next layer. And I'm going to go ahead and make sure that I've got this nice and smooth for our next layer and everywhere I want the material to be. So I've got that ready to go. At this point, I'm going to go ahead and bring in my light. Now, when I cure this, again, I'm going to cure that for at least 10 seconds with my curing light. And I'm using that Velo, which should be outputting at 1100 milliwatts. And you can hear a slight beep when this is going. So it's giving me that full cure, and I go across there. At this point, I'm going to switch my guns, and I'm going to switch my the material inside my gun. I've got the deepest part done with my flowable. Now I'm going to take my Evanesce conventional composite, and as I mentioned earlier, I had hand selected a shade that I believe is the right not only shade but opacity for this restoration. Now, I'm going to back my camera out for just a second because I want to give you a little clinical tip. So bear with me. I'm going to back out here, okay? And I'm going to refocus that. So I've got my gun here ready to go. But you know, with most composite guns, this orifice is actually quite large. What I see too many clinicians do is attempt to come in here and somehow squirt their composite into the restoration and then drag it in some way to get the material off. And that leads to little shards at the end. So here's what I suggest you do. You take your gun, and with the composite ampule pointing upward, straight up in the air, you express composite, okay, right out of that gun. And then using that REJ number 10, you slice off precisely the amount of composite you want to place in the restoration. Then my gun goes immediately back into my warmer. I'm going to bring this back here to focus now close up. And I'm going to go ahead and place my first little layer of the composite. Now I do this usually towards the distal because it is, in fact, for me, the most challenging. And when you're placing this, remember, this is a highly filled composite. And as such, it requires a little bit of force. But the beautiful thing is I've warmed it to 150 degrees. And I've got 2 minutes of working time to get this where I need it. Now I'm trying to get all of this distal portion placed. And I want to make sure that if I do start to bring it towards the mesial, that I've got it placed in such a way that I'm not going to get myself into trouble. Now I can flip over the instrument and I can use that curved edge just as a little burnishing instrument to burnish this. Okay, so that's the REJ10 in use for that. Now, the other little trick you can do is if you want to pre-clear the margin, you can actually take an Explorer tip and just very lightly clear your margin. And that saves you a ton of finishing time. Now, we couldn't do this if we didn't have the cord in place. So with that, I placed that distal aspect, okay? Now I'm going to show you that I'm not at full contour yet. I haven't cured, but I'm getting there. See that contour? We're a little better. It's really important, though, as you place these, you get in the habit of having the patient turn to the side and you kind of look at your overall contours on the facial. And I love turning the patient to the side and then just kind of sculpting that how I want the restoration shaped. Okay. So at this point, I'm going to go ahead and get this restoration cured. Now, I haven't placed the final layer. I've still got a little bit more composite to place. So I'm going to go ahead and cure this. Okay. I'm going to give that full 20-second cure. I don't mind investing a few extra seconds in the curing process. So I get that all cured up and my light will turn off automatically. It's programmed to do that. Light is off. That signals to me to go back and grab my composite. Now, here's the trick in practice. I'm not doing the curing. My assistant is. What I'm doing while she is curing is I'm expressing the next bit of composite. So while she's curing, I'm sitting back. I grab my gun. I slice off precisely what I believe I need as my next layer, and this should be my final layer. And I'm standing by while she's curing, okay? Then I'll come in and place the restorative material with the spatula end, and I start then condensing the material. Now, if I bring in a little bit too much, not a problem. But remember, I have the mesial half of this now to fill. I'll come back and just slightly overlay that onto the distal. I'll use the side of my instrument to burnish. And when you're doing this, you want to use very light finger pressure, very light pressure in your hands. Now, the other thing that's nice about this composite is it's so sculptable that we can really put in that height of contour. We can ensure that we've got the depressions in the mamelons where we, those facial developments where we need them on the tooth, not the mamelons, I'm sorry. And I can get this margin nice and smooth just by using a little clearing technique with either the spatula end of the REJ10 or, as I showed you previously, if you notice right here on the mesial, I've got a bit of material. I want to make sure that I can clear that ahead of time. So just like that, I can really get that little indentation that goes into the side of a premolar cleared. I can come in here and I usually push towards the distal for the distal and the mesial for the mesial. I can come in here with an Explorer and just kind of go over this. And before I cure it, what I want to do is I want to look at this and make sure I'm happy with where I've got this. And I want to really make sure I've pulled the material into all of those irregular bevels, because that's really what's going to help hide this product, okay? And it has a really nice chameleon effect. Now, the neat thing about what I'm about to show you is I can actually get the height of contour completed ahead of time. So notice when I turn this on its side, how I've established that contour that mirrors kind of an average between that cuspid and premolar. And that's really important with those first bicuspids. So at this point, I do a quick little inspection. I say, okay, we are good to go. Okay. So I would reintroduce. Now, my assistant knows that as soon as my hand leaves the tooth, she would come in and cure the restoration. Now, when my hand leaves the tooth, I've got that REJ10 in my hand. I go immediately back to my composite and get out the next layer of composite that I would need for the restoration. So I've got this to the point where I'm curing it now. And then I would give it a final inspection and determine whether or not I need to place any additional material. Hopefully you can do these in 1 or 2 fills. Now this one, the one we simulated for you, is a very deep abfraction. This is one technique I use for those. So at this point, I'm going to switch and get into my contour and finishing protocols. So we've got the restoration placed, and I can now go ahead and I'd remove the retraction cord because I'm going to introduce a burr down to the gingival. Not only that, I can take an explorative, the same one I used earlier, and run it along that gingival cavo surface. And what's nice is by pre-clearing that, I have very little gingival contouring to do. So I'm going to go ahead and grab my burr. Okay. And I'm using a fluted carbide burr in my high speed. And I'm going to go ahead and do this. Now, one error that's made too frequently is clinicians tend to get too flat along here and they'll remove the height of contour. So when you're doing this, I'm going to turn this tooth on its side. We want to make sure that our burr is angled away. So we're only really cutting in the cervical third of the area we're working on. So I'm going to go ahead and get my handpiece rolling. Nice high speed, light pressure here. And very lightly. And I do that by feel. And I actually will even use the tip of the burr to let me know where I've got flash to remove if there is any. And that gets particularly complicated in the interproximal, especially on some premolars that have that nice little concavity on the mesial or the distal. So really quick finishing. Then what you do is you take your explorative, you come back in here and you just feel, and you want just dead smooth from that root surface all the way around, no catches whatsoever. Okay. So we've got that. Now the next phase, I'm going to switch to a latch lock, and I'm going to use the contour discs from Clinician's Choice to take and contour any little line angle. Now these happen to be what we call a one-sided. So if you look, this one's shiny. The other side is relatively opaque. That's because it has a cutting surface. So these only cut in one side, which is very useful for these. So I'm going to come in here on the mesial. And I really just use discs to get into that mesial facial aspect of the tooth. So I just do a little finishing there with that. Then what I can do is flip this disc over. So I flip it over very quickly. This happens to be the darkest color one, the kind of bluish color, the most coarse one. So I'm going to use this now and come on to the distal aspect. So I'm going to come in here and again, pretty slow speed and just get that nice and smooth. Okay. Just to help with those line angles. Now at this point, I'm going to give us a little air. Bear with me. Okay, I've got my little air in place. There, I've got the restoration all done. What I don't want you to do is take this disc and remove your height of contour. Okay, so watch that facial height of contour there, okay? Don't remove that. Now I'm gonna go ahead and switch, I would switch to my next, well, of course this, sorry. I dropped it on the ground, but I'm back in the game. Don't do that with patience, by the way, pick things off the ground. So I'm gonna go ahead and I've got it pointing distally now. I'm gonna go ahead and contour just a bit there. Get that nice and smooth. Going to come through now on the mesial, and I'm going to come through the mesial and get this mesial line angle nice and smooth. And that's all the finishing I'm going to do with a disc. Now, sometimes if you really manage that area quite nicely, you don't have to do a lot of this finishing. So I'm going to take this, give me a second, blow it off. So now what I want to do is I want to check my height of contour, because that is would be finished with a burr. So there we are, and I'm going to turn this to the side and make sure I've maintained that height of contour, which I have. Now, if you need to adjust your height of contour, you can use the disc, but don't do that initially if you don't need to. So if I need to flatten this a little, that's where the disc can come in now and just do ever so small amount of flattening, okay? So we do that, we get a nice and smooth. And of course, I would be doing these in a quadrant across the area. Now, the next phase of this is going to be to go ahead and get a high luster on this restoration. So what I want to point out here when you look at this restoration is really how shiny these two Type-It-On teeth are. Okay, and we'll say those are simulating the shine of enamel, but how matte my finish is on the composite. And that's because obviously I've been finishing this composite. So I'm going to introduce you to these ASAP, what are called ASAP dailies. This is the purple one, and I'm going to use this on the surface of this restoration. Now, these are beautifully shaped to be used kind of in two directions. So the first thing I'm going to do is going to take this, and I'm going to kind of just bounce on this tooth, okay? And I've got this kind of, now light pressure, lots of little speed. Now I'm going to flip it the other way. So if you notice, I want you to see how this spins. It's spinning up towards the occlusal, okay? Up towards the occlusal. When I flip the handpiece this way, it's still spinning in the same direction away. And that's really the habit I want you to get into. Otherwise, you're going to be spinning this towards the gingiva, and that's where you can cause some real trauma. So I've got it spinning. So I do that little trick. I'm here, and then I flip it over this way. So it's always spinning away. And that's really helpful in a class 5. Now I can come up here and just smooth that out. Now at this point, we should see a mini luster starting to occur, okay? Not a lot yet, but you can start to see we get a little reflection, okay? That's in that step. The next step I'm going to do is I'm going to go ahead and hit this with the 3 to 6 micron ASAP daily to really establish that high luster. And again, I'm going to use a bouncing speed. And I want you to see what occurs. Now I just hit that for a few seconds. Okay. So take a look at the distal there. See that luster on the distal? Now I haven't hit the mesial half, and you'll see that. Now I'm going to flip. Remember, flip your direction. Come over here. And now I'm going to hit this here on the mesial. This is one of my favorite products. I cannot live without the ASAP polishers. I mean, it just really polishes resin like nothing you've ever seen. Okay, so at this point, I'm going to give this a little air. Okay. Now, the other thing I want you to appreciate is not only did I get a beautifully high luster on this, take a look at that luster. It just equals that of enamel now, but it's helped me maintain my anatomy. So take a look down the side of this tooth and look how that contour with the cuspid is identical. And we've really maintained that anatomy. So that's really important, that you've got a polisher that not only polishes, um, but it maintains anatomy. The way it does it is by these little unique designs of the finisher itself at the tip. Now, the one I also use in practice is the same polishing material called the ASAP, the standard version. And these are the ones that are autoclavable, not for just the day, but for up to 30 uses. And these you polish in the exact same way. The difference is they're slightly larger, they're in a metal shank, and they're designed to be autoclaved multiple times. So with that said, I'm going to turn it back to Adam. We've got just a few minutes left for questions, and I know we've got some, so he's gonna funnel me some questions. And I want to thank Schein for having today's program, and I want to thank you all for listening. And I really want to encourage all of you to join me at Hands Online Live, or Bob Margis or Dr. Chan, whomever, and take one of our courses. They're a lot of fun. You'll learn a lot. You'll get some neat materials as samples. And I just can't encourage you enough to learn with us. So thank you again for attending today's program. Hope it was helpful.
Excellent. Thank you. Let's get right into those questions. The first one is, if the curing light is underperforming using the testing device, can they be repaired, or do you have to get a whole new one?
So that is a great question. And the short answer is they can be repaired. In fact, oftentimes you can lose, like for instance, in the Velo, you could lose one of 4 LEDs, and that would be a sharp drop in performance. Sometimes it's just wiring that's starting to corrode just a bit and losing the power to the source. So yeah, most of the time, an LED that's starting to taper off does not necessarily need to be replaced. It could be serviced, and most companies will do that for you.
What are your considerations for the prep of the gingival margin? Is it the go for it.
Yeah. So what do I do in the gingival? Basically, I don't do a lot in the gingival margin. If there's decay, I'll remove the decay, but I'd like the gingival margin to be as close to a butt joint as possible. We don't bevel the gingival margin because that gingival margin isn't in enamel. It's generally in dentin. And beveling dentin has absolutely no advantages. It doesn't really increase bond strength at all. And it doesn't make it any easier to restore or finish. So get a butt joint on there. Usually the lesion provides you that, except in the case of caries. I leave the gingival margin pretty much well enough alone.
Is the flowable composite preferred compared to a non-flowable for a class 5 composite?
So that's an interesting question. Which do you prefer for a class 5? My preference is a flowable. One thing the flowable does give us is being a little less filled. It's a little more elastomeric, meaning that area of the tooth tends to bend more than, say, the occlusal portion, and it's less likely to pop out from occlusal load. So I prefer at least lining with a flowable as the first step and then overlaying with a conventional. But honestly, I restore flowables or class 5s with 100% flowable all of the time. If you take our Hands On Live course, I'll go over that technique in addition to this technique on those 3 restorations.
I was just going to ask you about that, and you knocked it out. Let's see. What was the name of the flowable composite that you used?
So this is Evanes Flow from Clinician's Choice. This one happened to be an A1 dentin, but remember it comes in 3 opacities: the enamel, the dentin, and then something right in between the dentin at 85% opaque. That's a great product for those to stock a lot of enamel and dentin opacities. You just get the universal and go with it.
Do you freeze your patients for class 5 restorations?
Do I freeze them?
Yeah, it says you freeze patients for class 5 then as you are placing cord.
I mean, do I give them anesthesia?
Yes, probably.
Okay. So yes, I do give patients anesthesia for class 5s. Generally speaking, I'll do a buccal infiltration with a 4% septicane solution. So if I'm doing a quadrant, say I'm doing these 3 teeth here, I would anesthetize right over the center tooth with one carpule of Septicaine, and I'll get all three of them nice and numb. It's especially important, even though they may not feel the restoration, they will feel me cord packing, those type of things, or even finishing down there. So I want them to be comfortable.
Would the irregular bevel cause more sensitivity if the filling needs to be redone in the future?
Well, no, it should not, because remember, the irregular bevel is placed in enamel, so it should not increase sensitivity at all. You're not really doing that on the dent, you're doing that on the enamel portion of the preparation. So it should have no impact on that at all.
Will there be any stains on the composite where the irregular bevel is placed?
No, in fact, you should see less stain with less microleakage. Now, if you're having staining on the cavo surface of a composite, especially on the enamel, I really think you need to go back and look at your bonding protocol. What bonding material are you using? Does it have a high bond strength to enamel? Because really, if we do this properly, we should see no staining on margins whatsoever.
Two-part question here. Part one, do you soak the cord in hemodent? And part two, can hemodent affect the bond strength or cause staining?
So I do not soak my cords in hemodent or viscostat or anything unless I've got serious bleeding. But the reality is I shouldn't, because remember, we place that cord right at the beginning of the procedure. So generally speaking, I do not need a hemostatic solution unless the patient's got kind of uncontrolled gingival bleeding just by touching it, meaning their hygiene is poor, they've got some systemic issue. But generally speaking, I go in and I place the cord just after anesthesia, where I haven't traumatized the area at all. There should be virtually no bleeding and no real need for a hemostatic solution. And a hemostatic solution can decrease your bond. So I try and stay away from those. Now, if you had to do that and you had some bleeding and you placed some hemostatic solution, you can go ahead and clean off the prep after you've got hemostasis with a little alcohol, and you'll be just fine.
Got a couple questions on if you ever place retention grooves, or do you give any retentive grooves in worn dentition cases?
So in general, I do not place retention grooves on any class 5. The only place I'd consider it is if they're heavy bruxers where we haven't got them, say, in a night guard, or they're not wearing a night guard. But the reality is, if you're using some PA Max with a very high bond strength, then retention shouldn't be there. Try lower bond strength, pop out on. Every good technique. So generally speaking, kind of those retention grooves or retention slots or whatever you want to call them, were really designed for the old class 5 GV black design where we'd hammer gold into it or place an amalgam. So we don't need that mechanical retention because we have bond retention.
How do we prevent gum trauma if the margins are deep?
So there's really no way of preventing gum trauma per se, but you want to be really careful in a thin gingival biotype. We know they're thin gingival biotypes because they've got that really see-through tissue. They've got a lot of generalized recession. So with those, you want to use the smallest retraction cord you can get to go below your margin and be as atraumatic in placing the cord as possible. Then when you do your finishing, make sure to pull the cord prior to finishing, and you should cause very little trauma to the tissue. But if you're trying to place too large of a cord, you can have real big issues with traumatizing the tissue and potentially cause further recession, which we don't want to do. So keep the cord small, and you should avoid that.
What do you use when you get a little bleeding?
So if I do get a little bleeding, I'll use it one or two products, one called Viscostat Clear from Ultranet or standard Viscostat. Viscostat Clear is aluminum chloride. Viscostat Standard is ferric sulfate. I prefer the aluminum chloride because it doesn't stain the area as much as the standard Viscostat with the ferric sulfate. But either product, if you got a real big bleeder, then you may need to turn to the ferric sulfate.
Why do we see a dark shadow between filled resin and tooth margin?
Why do we see a dark shadow? If you see a dark shadow between your material, it usually means the opacity you selected wasn't great enough. So what happens with too many composites, if you're using enamel shades and you haven't used an opaque shade, say, and the tooth is relatively opaque, that enamel translucency will show through as gray or darkening in that area. So that's a real common mistake that you see when you select the wrong opacity, not necessarily the wrong shade.
In a class 5 with very smooth, shiny, sclerotic dentin, should you use a diamond burr to roughen up the dentin prior to bond?
You should do something to the dentin, and you want to remove that really highly polished area. So either a diamond burr, little round, 4-round diamond burr is a great way to roughen that up. Or if you happen to have a chairside micro etcher like I do, you can micro etch the surface of the dentin. And that really, really gets you a very, very good surface to bond to. So my preference would be a micro etcher. Second best thing, and still a very good option, would be a 4-round burr and a 4-round diamond burr going across that just lightly. Just need to get that shine off of there. And that's true. When you see that shine, those are usually abrasion lesions. They've been polished by the patient.
Is there any difference by using diamonds instead of carbides to finish the margin?
Not a huge fan of diamonds for finishing the margin because diamonds actually scratch the surface of the tooth, which is fine for a crown prep. But what that means is if you finish the gingival margin with a diamond, you have more of a potential to scratch or scar the tooth. And I prefer a carbide for finishing, especially down in the cervical area. A diamond burr could be used as a first mode if you've got a lot to contour back because it is more efficient. But I don't like to finish with a diamond. I'll use a carbide.
All right, we've got a couple more here.
Great.
Just had one. How thick or thin is the layer of flowable?
Well, the layer of flowable could be anything from, say, 0.5 millimeter to 1 millimeter to the entire restoration in flowable. With that said, remember, we are doing incremental layering to prevent massive shrinkage of the composite. So no more than 2 millimeters thick for that first layer. If you intend to do the entire thing in flowable, which is fine, you'd still want to keep that first layer to under 2 millimeters.
Is the irregular bevel mainly just for aesthetics or for better bond?
It's actually for both. That bevel does two things. It really helps hide the restoration, and it also increases surface area to bond to. So, and that's why we originally placed the bevels to get a higher bond strength. And there's a number of studies that showed these bevels on the enamel of a class 5 really do increase the overall bond of the restoration.
Do you prefer composite or any other material if it's subgingival?
All right, so you really have to consider what caused the lesion. If it's a carious lesion in a high caries risk patient that has uncontrolled disease, I actually would lean towards a glass ionomer or even a resin modified glass ionomer. However, if the disease is biomechanical from grinding or clenching, if it's from toothbrush abrasion or erosion from acid, I don't have to worry about decay. So that's when I'll default to the use of composite resin. Now, if the patient has caries and they've got the disease under control, I'm fine with composite resin as well. But if it's out of control disease, look to your GIs.
Do you like to use composite finishing burrs?
Yes, I like to use composite finishing burrs, but I won't use, say, a 3-step technique. I won't do red, yellow, white. I'll do the red, get it nice and smooth, and then go ahead and finish the rest with my ASAP and my discs.
Why use a carbide rather than a diamond burr for the irregular bevel?
You can use a diamond if you'd like. It really depends. diamond works fine for the regular bevel.
Do you use any fluid in the finishing process?
Well, you'd want your dental assistant providing just a little water as you go, because you don't want the teeth to heat up, especially with that second phase when you're going after the high luster. But no diamond polishing paste or anything like that. Just a little water put on the tooth to keep the temperature down as you polish.
Let's do one more here.
Great.
Any special technique for dentin bonding?
Well, if you're exclusively on dentin and no enamel product, then my suggestion would be you look at a self-etching adhesive, say Peak Universal with Peak SE from Ultradent, a self-etching adhesive, Scotch-Bond Universal from 3M, one of those products. But if you're on a combination, then I usually use a selective etch technique with a self-etcher or a total etch technique with a product like MPA Max.
Great. Well, that'll do it for us tonight. I would like to thank you, Dr. Geisberger, for your time this evening. We did get a couple questions about the products used in this presentation. Keep an eye out for the email with the recording sometime in the next week, as we will also include a complete product list for you as well. In the meantime, though, if anyone has additional questions about tonight's topic, please email us at webinars@henryschein.com. Additionally, if you're interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. I'd like to thank you all for joining us, and we look forward to seeing you back here soon. Thanks.
Thanks, guys. Have a good evening. Bye.